Good afternoon. I'm Dr. Divya Raghavan. I'm a transplant nephrologist from the University of Utah. Thank you for inviting me to give this talk. I'll be speaking about a case of antibody mediated rejection in a zero antigen mismatch kidney. Here's the disclaimer. I have no financial interests to disclose. Here's the case. The patient is a 43-year-old woman with a history of end-stage renal disease secondary to lupus nephritis. She was admitted for a deceased donor renal transplant. This was her fourth transplant. Her first two transplants were lost because of rejection, and the third transplant was lost due to BK nephropathy. As you can imagine, she is highly sensitized with a CPRA of 100%. She received a zero antigen mismatch kidney. It was also a very good quality kidney with a KDPI of 1%. She underwent induction with thymoglobulin. And for immunosuppression, we had her on tacrolimus, mycophenolate, and steroids. She had good urine output post transplant. However, her serum creatinine did not decrease as much as we expected. It remained around 2. As a result, we did a kidney biopsy at post-op day 7. This was the result. Here you can see that this is a very good looking kidney. We don't see any significant inflammation or scarring. That was low power. Now this is a more high power view, but we basically see the same thing. The tubules look quite good. They're back to back. There's no significant inflammation. There's no tubulitis or peritubular capillaritis. You see the same thing here. Here we have a glomerulus. It looks really good. The capillary loops are open. There's no glomerulitis. Now, the only positive result from the biopsy was the C4D, which is diffusely positive, as you can see here. It's positive in the peritubular capillaries. This was the biopsy report. So we had positive C4D, but no evidence of T cell mediated rejection and no microcirculatory inflammation. At this point, we weren't entirely sure what was going on with the patient, but we decided to treat her empirically for antibody mediated rejection. And the reason we decided to treat her is because she's highly sensitized. So we gave her plasmapheresis, IVIG, and high dose steroids. We also sent non HLA antibody testing, which came back positive for angiotensin type 1 receptor antibodies. So for follow-up, her creatinine improved to 1.4 after treatment, and then slowly went back up to 2.2, and then came back down again to around 1.6. We did another biopsy. This was about 3 months from the previous biopsy and 3 months from transplant. And this time around, we sent a sample for molecular microscope testing. This is the histology. Here you see the tubules. They're not back to back. You do have some inflammation that's visible here. And again, you do have a little bit of inflammation here, though we don't really see any tubulitis. Here you have the glomerulus, which doesn't have any glomerulitis. Here you have an artery with focal endothelialitis. So the biopsy report came back as BAMF2A T cell mediated rejection. There was some mild peritubular capillaritis, but the C4D was negative. If you remember, the C4D was positive in the first biopsy without any inflammation. However, in this biopsy, we have focal endothelialitis and mild peritubular capillaritis. We admitted the patient to the hospital and started her on IV steroids. We also ordered thymoglobulin to treat her BAMF2A T cell mediated rejection. At that point, we got the results of the molecular microscope testing, which was discordant with the histology. So this yellow triangle is our patient, and R5 corresponds to fully developed antibody mediated rejection. This confused us, but we felt that she most likely had antibody mediated rejection based on her clinical history. And so we decided to cancel the thymoglobulin and start her on treatment for antibody mediated rejection. So we did plasmapheresis, IVIG, and rituximab. She responded well to the treatment. Her creatinine had peaked at 3.1, but came down to around 1.6, 1.7 after treatment. As time went on, it slowly started going up to around 1.8 to 2. We were able to start her on losartan, and we did that because of the angiotensin receptor antibody that she had. We wanted to do it earlier, but her blood pressure was low and she was requiring midodrine to keep it up, so we had held off. We also got a repeat kidney biopsy at 6 months post transplant, which is 3 months post the second biopsy. And we also sent a sample for molecular microscope diagnostic testing. Now, the following slides would show the histology that she had. So here you have the tubules. There's no tubulitis, but you can see that she does have some peritubular capillaritis here. Here we have an artery. It looks really good. She does not have any endothelialitis, which she had last time. Here we have a couple of glomeruli. One of the glomeruli is showing mild glomerulitis. This is the biopsy report. She had mild microcirculatory inflammation and negative C4d. So the pathologist called this mild/resolving antibody mediated rejection. So this time around, we waited for the molecular microscopy report. And this is what it showed. So again, the yellow triangle is our patient, and R5 is fully developed antibody mediated rejection. So even though the histology showed mild antibody mediated rejection or resolving antibody mediated rejection, the molecular microscope revealed severe antibody mediated rejection. So we admitted her to the hospital again. We treated her with plasmapheresis, IVIG, and bortezomib. Her serum creatinine was around 2.2 on admission and came down to 1.7 on discharge. So currently, the patient's creatinine has gone up again to 2.5. Unfortunately, her blood BK virus is now positive. So at this point, we're scaling down her immunosuppression. We reduced her mycophenolate. We continued tacrolimus and prednisone. She's still on the losartan, and we've ordered IVIG. It's very probable that we'll have to do another biopsy to see what's going on with her. But hopefully she does well. Here we have kind of a summary of her biopsies. The first biopsy showed positive C4d and nothing else, no inflammation. I feel or I suspect that if we had done the molecular microscope test at that point, that it would have shown antibody mediated rejection. Now, while we did end up treating her for antibody mediated rejection, that would have made us more confident in our diagnosis. The second biopsy actually was read as T cell mediated rejection, and here the molecular microscope actually flipped the diagnosis to antibody mediated rejection and helped us give a more appropriate treatment for her. And to tell the truth, I was very surprised when I got the diagnosis of T cell mediated rejection, and we felt her clinical picture was more consistent with antibody mediated rejection. So this kind of confirmed things for us. And the third biopsy, which showed mild/resolving antibody mediated rejection, also made us believe that the second biopsy did represent antibody mediated rejection. So in her case, I really found the molecular microscope to be very helpful. This was my first time using this technology, and I hope to use it more in the future. I want to acknowledge all the people who helped out with this case. We have an excellent transplant team. I want to point out Dr. Isaac Hall, who went to a lot of trouble with the logistics of sending the sample, FedExing it to the lab, and following up on the result. I also want to thank Dr. Ravello, who read all the biopsies and was able to send me these pictures on short notice. I also want to appreciate Dr. Chris Lawrence. I had extensive discussions with him when we got the conflicting report from the molecular microscope, and he was really helpful in trying to figure out what to do and how to interpret the results. I want to thank you once again for having me give this talk. I hope you have a wonderful rest of your day.